I'm Steve Charles in Memphis, Tennessee. So what I thought I'd do is to give a lecture on techniques for diabetic traction retinal detachment surgery. I go to meeting after meeting, as many of you do, and I hear constantly this concept, there's no need for scissors anymore with modern cutters. The notion that you don't need to know how to use scissors technique is simply wrong. And so the first point I'd like to emphasize is that if you're going to do diabetic traction attachment surgery, avail yourself of the fastest cutting rates, the beveled cutters, the better fluidics, and it'll help, and you can do most of it. Epiretinal membrane, most of the traction attachment. Think of if I had to put in oil, I probably did a bad job in surgery. That's rude to say, maybe some people might interpret it that way, but silicone oil does not support oxygen diffusion, and these retinas are oxygen deprived. And the results of diabetic traction attachment cases where oil had to be used are simply miserable. And you ought to think of every way to not make a retinal tear if you possibly can. If you try to do a tabletop traction attachment, if you try to remove densely adherent epiretinal membrane over the macula, you will make retinal breaks. And if they're big enough, you'll be pushed into using oil and you'll get a bad outcome. Lens management is a nightmare. Cataract management in the context of oil. There's no good way to do it. If you do a phaco, the capsule gets fibrous and you can't yag it with if oil's behind it. So you almost have to make them aphakic and leave the oil in these difficult cases. So think about if I did oil, I didn't do it right. I'm stunned when I hear people say the first step is to make a PVD. If you've got a diabetic traction attachment, never ever pull in the vitreous and make a PVD that way. You'll need to you need to recognize that the posterior vitreous cortex is contiguous with epiretinal membrane. And so as you do the case, you will ultimately have a PVD. But don't grab vitreous with the cutter and pull on it to make a PVD in a diabetic traction attachment. Because not only will you make tears at the outer edge of the arcades where the retina is thin and ischemic, you'll make tears in the periphery and not even see it if there's any vitreous hemorrhage. And that's an absolutely terrible thing to do because you're going to end up with a postoperative detachment and very bad outcomes and with neovascular glaucoma, et cetera. And rows of laser in the periphery or an unnecessary buckle are not the solution. So let's come back to what should you do then? If the vitreous, always bear in mind the continuity of the posterior vitreous cortex. It is attached to the outside margin of every center of epiretinal membrane, so the peripheral edge of it, and every epiretinal membrane area along the arcades. Unless there's a little defect in the posterior vitreous cortex over the macula, and for the most part, there's always vitreous between it. So there's no such thing as a vitreous band. Think about this continuity of the vitreous cortex. It has multiple layers. Put membrane peeling behind you. Occasionally, the membrane will be easy enough that as you try to remove it with the cutter, it will peel free. Occasionally, the PD will present itself as you're doing it, but don't think that way. Think about, I'm going to do this by sharp dissection, not by pulling. Pulling is dangerous. Just try to put it behind you, that notion. So the idea there's some linear algorithm. First, you do a core vitrectomy. There is no core in the diabetic traction. It's a plate called the posterior vitreous cortex. Then you pull in the vitreous to make a PVD. Wrong. Don't do that. Think about going to the disc, the optic nerve head, where the epiretinal membrane extends along the arcades, and take the scissors and delaminate in an inside-out direction or the cutter if there are islands. Now let's talk a little bit about cutter delamination. To go back to my first statements, there is no question that the cutter with high cutting rates, beveled cutters, and better fluidics, that we're able to do more and more epiretinal membrane. But how? There's two discretely different methods. If the epiretinal membrane is a plate, if it's thick, if it's dense, if it's inflexible, then you've got to hold the cutter right approximated to the edge. You've got to hold it just like so. So that, and I call it conformal cutter delamination. What does that mean? That means that since the retina folds up and down, you've got to feed it in the edge, but you got to have a little up angle. You got to have the port up rotated like this, so that a little bit away from the retina, so you don't suck membrane Simply feed it in and carefully approximating at the edge, rotating out. Now to your overall goal. The overall goal at a minimum is to get the macula attached. That's where central vision resides, as we all know. Secondary goal, get the posterior pole attached. Epiretinal membrane isn't cancer. Your goal isn't to get it all out. Retina with epiretinal membrane, leave it alone. By managing the posterior vitreous cortex. Now to an often used term, which is ridiculous, en bloc. En bloc means in one piece. En bloc is absolutely essential in cancer surgery so that you get the proper histology and cancer margins and you don't spread cancer cells. It has nothing to do with diabetic traction detachment surgery. It's a ridiculous term that never should have got in our field. The original paper on it said, pull on the posterior vitreous cortex to lift up epiretinal membrane. Got to be the stupidest idea you ever heard. It's a great opportunity to make retinal breaks in the periphery that you can't find and can't treat and result in retinal detachment and bad outcomes. So forget en bloc. Where does segmentation fit? I invented segmentation, which means cut the membrane into pieces, and then a couple of years later, I invented delamination. What's the difference? Membrane into pieces, so the traction along the retina goes away, so the retina can, as the epiretinal membrane epicenter separate, the retina has enough release of traction to go back against the pigment. Delamination means put the scissors underneath the membrane and remove it, like so. So cut it up, cut it off, okay? The recurrence rate is less with delamination, and there's less atrophic retinal breaks. So where does segmentation fit today? Segmentation fits as an access tool. So now what scissors should you use? I've been preaching to learn the skill set of scissors. Don't try to do it all with a cutter. I've been preaching this for quite a while now. Where do the scissors fit? Use curved scissors. Don't use so-called horizontal or vertical scissors. The blade width is greater in scissors. The back wall of the eye is curved. What about bimanual surgery? Unnecessary. I don't get it. I don't understand why you have to have it. If you use scissors that properly shear and you use them properly, you don't need bimanual surgery. When you do bimanual surgery, you got to use a chandelier for illumination because you're using both hands with active tools. And chandelier provides so much glare, particularly if there's cataract or a multifocal IOL, and it just makes it hard to see. So much better to use focal illumination with the endo illuminator so you can see what you're doing. So in this notion of access segmentation first, then inside out delamination, starting around the disc to free up the arcade so the macula will go on. Instead of the term en bloc, which implies in one big piece, while it might look impressive in a video, it's not what you want. Segment it into the epiretinal membrane into several pieces so you're not causing remote traction when you cut. Now, how should you use the scissors? Don't stick the scissors in the potential space between membrane and retina and open them. Don't stick the scissors between wide open and then closed. She'll tug on the retina and tear it. If you take the scissors and close them almost completely and just cut right at the tip, remember the scissors cut on a point, not on a line. And sharp scissors, they're square edges, they cut by shearing. And what you want to do with the scissors is to introduce them almost closed right at the little attachment points and sever them. What should you do about hemostasis? Well, hemostasis is obviously crucial. But if you use the diathermy extensively as you're doing this, you will create retinal necrosis, which results in retinal breaks. The instant you diathermize retina, it's weaker. Far to elevate the pressure to control any bleeding, and then later, if the bleeding continues, when you lower the pressure, use the laser for hemostasis. Laser hemostasis is far superior to using the bipolar diathermy for hemostasis in most instances. Why? Because the 532 nanometer green laser beam is absorbed in the red hemoglobin column, and the energy is delivered just to the blood column, and it coagulates. When you use diathermy, there's a much broader spread of the radiofrequency energy, hence necrosis, and patients later will develop large holes in posterior retina years later, and you'll call them atrophic or ischemic to excuse yourself, but it's actually created by the diathermy. Now, what about PRP? My recommendation is if you've got elevated retina, which is the definition of diabetic traction detachment, Don't worry about reattaching it intraoperatively unless there's a hole already present or you make one. If there are no holes, don't use gap. But never PRP that was detached pre-op. Why? We have the anti-VEGF compounds. You should have injected it a week pre-op or no more than a week pre-op, and you should inject the anti-VEGF compound at the end of the case anyhow. That's a better way to fight neovascularization. If you PRP retina was detached pre-op, always some subretinal fluid there, and absolutely down the path of excessive retinopexy, excessive necrosis, excessive inflammation, and fibrin syndrome. One program in the United States years ago reported hundreds of cases of fibrin syndrome. And in my mind, I traced that back to this notion of intract detachment, draining fluid, putting an air bubble in, and then doing a PRP. It results, and I'm repeating myself intentionally, in excessive retinopexy. So what are some of the crucial issues I brought up? Learn to use scissors. Always use curved scissors. Use them when the now updated methods of bevel cutters, 20,000 cuts per minute, better fluidics, are still make you concerned you're going to make a hole in the retina, particularly in the posterior pole, particularly in the macula. So keep that scissors expertise in your surgical armamentarium. Don't pull on the posterior vitreous cortex and make a PVD in diabetic traction detachments. Please don't do that. It's not the right thing to do. If you used oil, be self-critical. Say, I made a mistake. I shouldn't have done that. There are cases that are so bad that we have to, but think of every possible way to avoid breaks and to avoid oil. As a sidebar issue, you should never, ever, ever, if you make a hole in an ROP case and put in oil, it's over. You've blinded the eye. It's not good. You're not going to fix it. So keeping these things in mind, that oxygen supply can't happen in the presence of silicone oil. You can't have diffusion from areas of perfused retina to areas of underperfused. That's such an important concept to keep in mind. So let's talk a little bit about preparation before surgery. It's very, very important to sort through the patient's medications, say what should you continue to take on the day of surgery. Obviously, they should not eat or drink anything for 8 hours or so, but blood sugar management's crucial. And so what often happens is patients elect to not take their insulin the day of surgery, and then they walk in with a blood sugar that's too high to safely operate. If you try to acutely get the blood sugar down with insulin, you have concerns about potassium levels, so it's better to do a better job and bring the patient another day. Let's talk a little bit about PVR. Is PVR, or proliferative vitreoretinopathy? Rhetorical question. Is PVR kind of like cancer? If you get it all out, it doesn't come back? No, it's not. PVR is a keloid. It's excessive healing. What's the difference between healing and scarring? It's a functional definition. If you heal too much, it's called scarring. Is the biology different? No. The steroids get rid of, if you give them systemic steroids or subconjunctival steroids, is that going to prevent PVR? It reduces inflammation, but most of the inflammation is because of excessive retinopexy. So that's really not the answer. So at any rate, with PVR, think of it as a mechanical solution to make the retina reach. Sometimes that's best accomplished by retinectomy. Robert Mockemer, the late Robert Mockemer, recommended what's called relaxing retinotomy, which means make a cut in the retina, in his case under infusion fluid, and then leave all the tissue anterior. At the same time he developed that, I developed retinectomy. What's the difference? Retinectomy means remove all the tissue anterior to the cut. And so when I do retinectomy, I do it under air, because I've found that under saline, you could under or overestimate the amount of retinectomy required. So you start with removing the vitreous that represents the confluence of the anterior and posterior vitreous cortex in these PVR cases. Once you've resected that and brought it down to near the equatorial surface of the retina, then you address your attention to star folds. Starting in the posterior pole, an epimacular membrane is actually a star fold. If you think of it, it's a limited PVR. Take those with the forceps. Don't get underneath the membrane with picks or things. Pinch peel from the middle of the star fold and peel inside out. As you peel toward the periphery, often it'll surprise you, and you'll see a little star fold that'll extend to a broad sheet of tissue that'll peel right up to the equator, the posterior edge of the vitreous space, and stop. So peel as much as you can without damaging retina, peel out to the equator, and then begin to drain through a retinal break, then turn the air on, and as you do fluid air exchange, continue your internal drainage. When the retina starts moving back, if it halts, if it stops moving back to the pigment epithelium, that means there's either residual vitreous, in which case you should do vitrectomy under air, or it means, in failing that, if all the vitreous is properly removed and there's no what I call anterior loop traction, anterior to the equator, then something else is holding the retina up. Often, if the retina was bullous, as two bulla come apart, you can see a star fold between them. Peel that off. So peel under air. As the retina continues to go back, then if you say, gee, it still won't go back, but there's no vitreous, there's no membrane, what's holding it up? Often at that point, particularly if there's been turbid subretinal fluid you removed, you'll see a subretinal band, and you can remove that band at that point. So think of it as the reattachment experiment, starting front to back. Did I get all the vitreous out? And again, you're observing this under air. You're observing this as you do internal drainage of subretinal fluid, which you initiated before fluid air exchange. So the retina begins to move back. Did I find vitreous? No. Oh, I did. Vitrectomy under air. Did I find membrane? I did. Peeling under air. Forget PFO. The retina goes back farther. Oh, it's hung again. Oh, there's a subretinal band tinting the retina. Let's do puncture retinotomy and remove the subretinal band. Retina goes back. Still won't go back. It's corrugated at the inferior vitreous base along the inferior equator. It's so corrugated, so you make a little cut with the instrument, and if subretinal air appears, that means the retina won't reach. It doesn't mean you did it wrong and you got to start over. So continue to resect retina until you get it reattached. I call it incremental retinectomy. Once you've done retinectomy on the inferior half of the retina, often it'll extend up past the 3 and 9 o'clock position. Some people then extend it 360. I don't. But if it is as much as 270, I go ahead and do the other quadrant to make it a full 360 retinectomy. Then you exchange for silicone oil. Often in these very challenging cases, I don't use laser. Excessive retinopexy is one of the causes of PVR. So if you're going to have to do miles and miles of laser, think twice about it and use silicone oil for what I call rhegmatogenous confinement. For the purpose of retinopexy avoidance, reminding you that PVR is a keloid. It's not cancer. It's not, you get it all out and it doesn't come back. I wish it didn't say P in PVR as in proliferative, because there's very low cellular turnover rates. It's a keloid. So your goal is to achieve mechanical reattachment with minimal tissue destruction, brief surgery, and the minimal causation of inflammation. That is crucial.
I'm going to begin by, of course, inserting the speculum. It's very important to mobilize a flap of the drape over the upper lid and covering the lower lid as well to keep the lashes from being in the field of view. No matter how hard you try to prep, you can't completely sterilize lashes, and you certainly don't want to cut cilia off and have it end up inside the eye somehow. So use a drape without a window in it, without a hole in it, and cut it, transect it halfway between the upper and lower lid, so you have a flap to fold over the upper and lower lid. Very, very important. When inserting the trocars and cannulas, it's quite important. As you notice, I turned the light off briefly while we were preparing the trocars and cannulas for insertion. We want to minimize light exposure to the retina, both with the endoilluminator as well as with the operating microscope. Although clinical evidence of light toxicity is not readily available, there's no harm in reducing the photon flux to the retina during surgery. So when you insert a cannula using a trocar, it's very important to insert at a 30-degree angle. As you notice, I'm going to displace the conjunctiva toward the limbus, and then I'm going to impale the conjunctiva on the sclera with the tip of the trocar. I'm going to drop the cotton tip applicator. Then I'm going to take the hand that was holding the contip applicator and use the forefinger to press on the ferrule of the trocar shaft so I can hold the trocar at this 30-degree angle. If you notice, I don't use a forceps to stabilize the globe. If you do, you'll tear the conjunctiva. So that counter force from your other hand, your opposite hand from the one holding the trocar, it's basically a down force to preserve a limbus parallel 30-degree angle. Now the light's off while we're preparing with the forceps. Now I'm going to take the forceps and stabilize the hub so I don't put pressure on the globe when I insert the infusion cannula into this first cannula. It must be turned on and you should inspect it. The service loop, as you can see now, it must be carefully positioned so there's enough slack in the service loop of the infusion tubing that it doesn't pull out and cause a suprachoroidal infusion, and it doesn't flip the cannula forward so that you put air in the anterior chamber if indeed you were doing fluid air exchange in a phakic or pseudophakic eye. These are the service loop maintenance to make sure that you don't do suprachoroidal infusion. Very, very important. Again, 30-degree angle, no forceps stabilizing the globe. And so we insert the second one with the infusion running at the infusion pressure of 45. The reason for that is to make sure the choroid is properly inflated against the sclera so you can make sure that you've inserted the second and third cannula all the way through the choroid. Again, the forceps were not used to stabilize the globe. Someone pinched the cannula, the tubing for me so that fluid would not reflux into the cannula and vitreous wouldn't. And so now we're ready to go. With core vitrectomy, which obviously is the starting point of a primary surgery, it's really important to not pull back the cutter as you actuate. If vacuum is applied, don't pull back unless you're consciously creating a PVD and you're prepared to do 360 scleral depression to make sure you didn't induce an iatrogenic retinal break from PVD creation. The rest of the time, you should use a technique I call continuous engage and advance. So in other words, cut free before you move. In other words, don't pull back on the cutter when it's engaged. If you're going to volitionally make a PVD, you should go near the optic nerve head and pull straight back. You don't go side to side. The so-called fish strike maneuver is inherently dangerous, and I caution you against doing that. Iatrogenic retinal breaks are not just from contact between the cutter and retina in mobile retina cases. They're from acute traction delivered during surgery and from residual vitreous tugging on the peripheral retina and extending into the cannulas at the end of the case. So that's very important as well. So as you can see, I'm moving forward with core vitrectomy. Peripheral vitreous shaving is absolutely unnecessary and in fact can be detrimental in patients with undergoing macular surgery. If you're doing a macular hole, you got to get rid of all the vitreous so the inferior part of the gas bubble doesn't interact with the peripheral vitreous inferiorly and cause iatrogenic breaks. But if you're doing an epimacular membrane case, removing every bit of vitreous out to the retinal surface in the periphery has no advantage, and it increases the likelihood of an iatrogenic retinal break and bumping the lens in a phakic eye. So this is very important to keep in mind, that the idea that everybody gets peripheral vitreous shaving is an overdone notion in many circles in vitreoretinal surgery. So core vitrectomy, as you can see here, can be a bit boring, but it's necessary to do a good job. I always keep the endo illuminator pointed just in front of the vitreous cutter. I use reflected light from the vitreous cutter for retroillumination, and I don't use a chandelier. A chandelier is diffuse illumination. It kind of makes the video better, but it creates the problem of glare, particularly with multifocal IOLs. And it creates the problem of not being able to see vitreous as well, driving you toward having to use triamcinolone in order to do particulate marking, inappropriately called staining by some people. I always stain while we're on that subject. Kenalog is a particulate marker. Kenalog or triamcinolone is a particulate marker, whereas brilliant blue is the stain I use. So every time I do epimacular membrane surgery, macular hole surgery, vitreomacular schisis, I stain. In the United States, we can't use brilliant blue in some institutions because it's not FDA approved. So some surgeons use ICG. ICG is toxic and at many levels. And although there's not a lot of clinical cases out there with proven toxicity, I've certainly seen it in cases referred, operated by others. So I always use a brilliant blue stain. So now I'm farther along with the peripheral vitrectomy. We have wide-angle visualization in place so I can better see the periphery, verify that I didn't make an iatrogenic retinal break. And shortly, once I complete the 360 view of the periphery and a moderate level of peripheral vitrectomy, not excessive as I already discussed, now we'll move to the step of brilliant blue staining and membrane peeling. In this, when the membrane, the epiretinal membrane has a sheen to it, that means it doesn't have any surface features on which to grasp. I never use any form of scrapers or picks. I always use the so-called pinch peeling technique, which I developed many years ago, and that's highly dependent on using forceps that close at the end. I only use Alcon's DSP ILM forceps. I do not get a royalty on those, but I think they're essential. So now we'll put some brilliant blue in place to stain the retinal surface. We chill the brilliant blue and take it out of the refrigerator just before use so that it will, due to convection, it will go to the bottom part of the eye. Brilliant blue is advantageous because of its pH, its osmolarity, the fact that it's not toxic in tissue culture to RPE cells or glial cells, but it's also advantageous in that you dilute it in BSS instead of sterile water. So now we'll let this stain permeate the ILM and possibly epiretinal membrane for a few moments. And in ICG, those moments should be very brief. So I always, as I said, use brilliant blue. So now we'll put the cutter and the endoluminator, of course, back in place and remove the brilliant blue and proceed on for membrane peeling. Notice that we're checking the infusion cannula frequently. That's why it's wiggling a little bit, just to make absolutely certain it's in the right place. And now the contact lens goes in the eye. I much prefer contact visualization, even though it requires a more skilled assistant, to non-contact visualization. In short, I don't use the biome or the recite. I use a flat contact lens, a plano contact lens, as Macromer originally introduced when I'm doing macular surgery and traction detachment surgery, and when I'm doing the peripheral part of it or doing a retinal detachment, giant break PVR case, then I use contact-based wide angle. So now the brilliant blue is removed. I'm inserting the DSP ILM forceps, and now we'll begin to do some membrane peeling. It's important to move very, very slowly when you do membrane peeling. You're scaling up your position by virtue of magnification. Therefore, you must scale down your velocity. Velocity is the first derivative of position, so it's imperative that you do this as slowly as possible. And don't be concerned if several attempts at grasping the ILM are not effective in getting a purchase on the tissue. If it's real shiny, as it is in this case, there might be, as I alluded to earlier, not enough surface features to get good purchase on the membrane. But it's okay to grasp above it. It's not okay to once you think you've grasped, to be rather aggressive and then create a full thickness retinal defect. That is absolutely 100% of the time avoidable if you move slowly and you don't worry about the fact that you might, as you see here, I restained with the brilliant blue just to make absolutely certain I had a good view of the membrane. And again, the plano contact lens for visualization. And shortly we'll reintroduce the forceps, the DSP ILM forceps, and continue on with membrane peeling now that the brilliant blue is out of the way. You'll see that it typically takes several grasps when the membrane is shiny, has the sheen, in order to find a good location, and that shouldn't be disconcerting. Obviously, when you have others watching you operate as is happening here, it's a bit disconcerting. You'd like to be able to just grasp once and go, but if you're too aggressive and you grab nerve fiber layer, that's bad. So grasping, and if there's the slightest question that the grasp is too deep, maybe the patient moved up slightly as you were grasping, let go and move again. You're going to peel tangential to the retinal surface in a circular motion. Don't grab and lift. It's far better to peel toward the fovea or in a circular motion. So if it's highly adherent to the fovea, you don't create a macular hole. If you do, it will close with the air bubble. But again, this is avoidable. So as you can see, I'm moving very, very slowly and very carefully. And that's not because I'm making a video streaming presentation here. It's because I always do it that way. And I'm not concerned if a couple of grasps I don't get sufficient grasp on the ILM. So instead of pressing harder or using diamond dusted membrane scrapers or other instruments potentially dangerous to the retinal surface, I simply move to a new location and start again. If your hand begins to cramp or even develop a slight tremor in one location, move to another location and you'll recruit different muscles in your hand, and the cramping and potentially even a little tremor will go away. So here I've tried several locations, and now I've seemed to have found a better location for grasping, and we'll be able to obtain a grasp. As you can see, the staining with brilliant blue is not near as intense as it is with ICG, but what's interesting is that you don't see the staining so well, but once you begin to get a lift of the ILM, which you're starting to see now, then it becomes very visible. And that's an important thing to bear in mind, instead of being frustrated by the fact that the staining is not intense. So how far out to peel is a question that's often asked. Depends on what you're treating. The forces are directed inward to the fovea in epimacular membrane cases. And the way to tell in an EMM case if you've done your job is if all the stria are gone. If the stria, the little microfolds in the retina are not gone at the end of your peeling, stain again because you've missed something. You've missed ILM. That's a very important consideration. As you can see, the peeling is now going quite well, and I'm being very slow and careful with it, always keeping an eye on the fovea, not just the tips of the forceps. So my gaze keeps moving back and forth from the tip of the forceps and the grasp point, which is obviously necessary to grasp the tissue and to be safe. And now we've peeled it across the fovea. Now, how much should you peel if it was a macular hole or macular schisis case? You should peel all the way to the equator. When you take the cannulas out of the eye, it's very important to remove them on the trajectory you inserted them, namely 30 degrees. Very, very important to do that. So as you can see, I'm going to stain one more time with brilliant blue to make sure that I've got all the membrane removed and all the ILM improved. I remove ILM in every epimacular membrane case. The reason for that is that the stria go away on the table, as I alluded to, and as Anselm Kampnick has taught us, the recurrence rate is much, much less, essentially zero, if you do a good job of ILM peeling. So now you can see that I'm removing the brilliant blue, and there's some more ILM present. I think you can probably see it now on the TV, and shortly we'll go ahead and peel that with the ILM forceps as well. But with ICG, it's said to be dangerous to stain multiple times. With brilliant blue, it's the rule to stain multiple times to make sure you get all the ILM peeled appropriately. A large macular hole or macular schisis, you got to peel almost to the arcades because the force is outward directed. Think of it sort of like Hooke's law in physics, the spring equation, F = minus ky. The y is the distance. So you can see there was some more tissue that needed peeling that was visualized better once I restained with the brilliant blue. So shortly we'll have all that removed, and we'll be able to close the sclerotomies and answer any questions that the audience might have. Frequently, I've seen videos from other surgeons where they'll use triamcinolone, peel something, state that it's the ILM, but it really isn't the ILM. It's really the residual posterior vitreous cortex. The presence of a Weiss ring or an apparent PVD, either clinically or with OCT, does not mean that there's not vitreous on the retinal surface. That's why the classification system for macular holes that Dr. Gass came up with is completely invalid. And now that we have surgical visualization where we can really tell whether there's vitreous on the retinal surface or not. When I have dense membrane in the forceps, it'll often get trapped in the valve cannula. So what I do is move it to the anterior vitreous cavity with the forceps, take the endoilluminator out, put the cutter in with the other hand, and I can remove it that way. And that way, not have membrane stuck in the cannulas and particularly in the pars plana. Now, search for a residual tissue just to make sure we didn't leave anything behind. I'm meticulous about doing that. Often we can peel it in one step and we're done, and you restain, you don't see anything. But other times when you restain, you'll see a little bit of tissue that must be removed to make certain that there's no residual tangential force on the retinal surface causing retinal distortion and metamorphopsia for the patient. If you don't remove the ILM in these cases, the patients continue to have metamorphopsia even though the vision can be improved somewhat. And again, I see numerous cases where they don't use brilliant blue or ICG staining demonstrated at meetings where it's apparent they peeled vitreous and not ILM, and these patients are likely to have residual stria. So there's a little bit of tissue there in the PM bundle, and that was causing some stria extending from the nerve head into the PM bundle and on the nasal side of the fovea. Back of the forceps. One more time to check for residual tissue. The typical case takes 15 minutes. This is now at about 18, which is longer than usual because of multiple passes with brilliant blue and with the forceps just to make sure we got everything properly removed. So in one hand I have the plug forceps, and I use the smooth back part of the plug forceps to press the scleral tunnel together with the IOP on 45 millimeters of mercury as I withdraw the cannulas along their 30-degree insertion angle. This way you don't pry them open. Collagen is inelastic, so that pressure with the smooth instrument closes the scleral tunnel very nicely. A cotton tip applicator is simply inadequate to do this. It's not just about replacing the conjunctiva, it's about pressing the scleral tunnel closed. If you do that carefully, your incidence of wound leaks or needing to suture is extremely low. I do 700-800 cases a year and suture several times a year, less than 10. Some years I've only had to suture 1 or 2 cases. So again, I'm pressing with this smooth but yet firm metal instrument to push that inelastic collagen of the scleral tunnel back together. As you can see, no wound leak at all. This is 25 gauge surgery, and we'll do the same thing in the third port. And it's important to leave the infusion on during this procedure so there's a counter pressure to your compression force. The idea that you should turn the way down is simply inadequate. Do not remove cannulas over an endoilluminator, as some is recommended. That actually pulls vitreous up into the sclerotomies and is a bad idea. So we recommend against doing that. I use subconjunctival antibiotics and steroids at the end of the case. Some people don't. Of course, the cataract surgeons don't do that, but please recall in a 2-compartment eye, any topical medication has 1/100th of vitreous level of the anterior chamber level. So topical antibiotics simply do not penetrate to the MIC in the vitreous cavity. So now we're going to inject the antibiotics subconsciously. We do this in the inferior fornix. So if the patient gets a little subconjunctival hemorrhage, as you notice, there was a little reflux of the material. We use Decadron as well as 2 antibiotics, 1 for gram-positive and 1 for gram-negative coverage, basically. And we do this in every case. We use vancomycin if the patient is allergic to penicillin. So here's the third injection. We're really careful when we remove the speculum. So now I'm going to sit down in front of the webcam and attempt to answer questions that are submitted to me. The question was, but in phakic eyes with lens opacities, air will make the cataract worse and the table and the view can be inadequate for proper retinectomy. This is discussing the general topic of retinectomy under air. I've not found that to be the case. I found that if you perform surgery in an orderly, efficient fashion, taking 30, 45 minutes, I don't see progression of posterior subcapsular cataract unless there was a gas bubble already present in the eye from previous pneumatic retinopexy or a previous procedure. Then that is an issue. Then what I do is, since I do as much retinectomy as I can under air, but if the view is inadequate, I will then do air silicone exchange and complete the silicone, and that will then allow some clearing of the lens, so I can do the complete the retinectomy and laser confluently along the edge of the retinectomy under oil. The question is, why do I keep the intraocular pressure at 45? I do that because it reduces the meiosis. The pupil doesn't come down when the pressure is higher. The cornea isn't deformed by the speculum pressing on the eye or by the contact lens pressing on the eye, so the view's better and there's less capillary bleeding. The only times I reduce the pressure is if I see pulsation or inadequate perfusion of the vessels, and this is clearly would be the case in children where the intraocular pressure is lower because the blood pressure is lower, and in some patients under general anesthesia. Another question was, what are the stains? I use only brilliant blue. This is off-label in the United States. Hopefully a company will get it FDA approved in 2020. We've heard that to be the case, but it's the standard of care around the world. I never use ICG because it's toxic, even though 70 to 80% of American surgeons are forced to use it by being hospital-based. And so in America, the brilliant blue has to be prepared by a compounding pharmacy. Next question was, how would you like to make a 23 gauge incision? I never use 23 gauge ever. They have a higher incidence of wound leaks than 25 and 27. Another question was, an epiretinal membrane that causes pseudohole. Pseudohole is not a diagnosis. There is no such thing as a pseudohole. The word pseudo tells you that you need to figure out what it really is, and that's the purpose of preoperative OCT. Intraoperative OCT is not adequate because you can't resolve the ILM. But if there, in any case, in every single macular surgery case, I peel the ILM. If there's a partial thickness hole or schisis, vitreomacular schisis, or vitreomacular traction syndrome, I put in a 25% mixture of SF6. I never use an expanding bubble, and I never use C3F8. If there's only an epiretinal membrane, epimacular membrane, not schisis and not a hole, then I don't use bubble. If you don't peel ILM and you don't use a bubble in schisis cases or in lamellar macular hole cases, inappropriately called pseudo-hole by some people, they do not come back to normal foveal anatomy. Very, very important. How do I manage hemorrhage when peeling the ILM? Hemorrhage is usually caused by excessive downforce with your forceps, but sometimes the hemorrhage are very adherent and they bleed, and I transiently raise the intraocular pressure. This is maybe one case in 20 where you have to do this, but you would never use diathermy or laser or they would have scotoma. Next question was about searching for iatrogenic retinal breaks. Are there any cases when I do not do it? If I've not made a PVD, if the PVD was already present and there's cortical cataract making view of the periphery somewhat difficult, I might forego, but it's best practice to do 360 scleral depression. One way to accomplish this is to use the chandelier in the supranasal incision so you can scleral depress yourself, or you can switch back and forth with the chandelier from the supratemporal to the supranasal sclerotomy. How do I deal with the iatrogenic posterior pole breaks? First, you shouldn't make them in macular surgery. I probably have one or two in my whole life. On traction attachments, it certainly occurs. In traction attachments, you must relieve all the traction. So that means you're now committed to doing delamination, not just segmentation, in order to get the retina opposed to the pigment epithelium so you can satisfactorily perform retinopexy. And I manage them with SF6. Don't use silicone oil in diabetic traction attachment unless you just absolutely have to. Don't aggressively create PVDs in diabetic traction attachment cases. It's a mistake. Don't try to do it all with a cutter. Use scissors and to do everything you can to avoid iatrogenic retinal breaks. Very important. Another question was, the scenario was a dense epiretinal membrane and massive retinal thickening. Do I administer intravitreal steroids at the conclusion? I don't, because I believe it's structural thickening as opposed to actual edema. Everything that's thick is not edema, and steroids won't help. If there's cystic spaces, my experience is they go away just by removing the traction. Another question, what's the role of anti-proliferating agents like methotrexate in diabetic traction attachment? None. I think they would increase the risk of infection. You'd have to inject weekly for 8 weeks, as we understand from the fine work done by Dean Elliott on PBR. So I think I would not do that. The last question was, for a beginner, how do you learn to do ILM peeling? How do you understand you've only caught the ILM and not the retina when pinching? Number one is to go slow. Go very slow. Number two, don't feel bad about grasping above it, so don't be forceful. Number three, don't use scrapers of any kind. They're dangerous. And you must use a flat contact lens for visualization, and please stain with brilliant blue. Hopefully this is helpful. Thank you.